as we continue our sojourn to the year 2025 that is ASCO. We have none other than one of the original guests on our show, Professor Anthony Joshua. While this man does not need an introduction, I will give you all an introduction. So Anthony is, would you say the king of prostate, Michael?
If not the king, then maybe the baron or the earl of prostate.
I think the court jester, perhaps.
The court jester. I mean, it is Sydney, so to be a court jester in Sydney is pretty good. Either way,
high praise.
Anthony works at the Kinghorn Cancer Centre, St Vincent's Health in Sydney, and the Garvan Institute of Medical Research. He's an alumni of the Department of Medical Oncology at Princess Margaret Cancer Centre for all you Canadian listeners. So, he learned his trade in the wonderful world that is Canada. And he's here today to talk to us about prostate and maybe something testicular, but mostly prostate cancer and sort of the updates. And it's always an interesting world when it comes to prostate and these big global conferences, because things are moving at a rapid pace. But Anthony, so good to have you back on the show. How have you been?
I've been very good, thank you, Josh, Michael. Yeah, very good. Had a nice time at ASCO. It was a bit colder than normal in Chicago. But it was a good meeting, a solid meeting, not necessarily in GU, I think, but certainly other cancers had their time in the limelight, as I'm sure your listeners would have heard from your other ASCO podcasts. So exciting stuff in breast, GI, lung. GU took a bit of a backseat this year, but that's okay.
Yeah, GU has had such a prominent seat at the table in last few years. I don't think it could maintain such a high run of form. But despite that, Anthony, there are doubtless some things we were talking before we started recording that sparked your interest. So I guess what was the thing that made you sit up the most and say, hey, that's pretty interesting?
So the probably in terms of if I had to pick a highlight, it would probably be the AMPLITUDE study. But I can just sort of tell the listeners a bit about what was on at the orals in the prostate testicular penile session that warranted attention. So just to sort of talk through them in terms of the talks that were on, there was a intraprostatic a virus injection which was activated by valacyclovir and for example, or acyclovir that is called CAN2409. That was a very interesting study, which is a phase 3 randomized placebo-controlled clinical trial of this intraprostatic injection in combination with the standard of care external beam radiotherapy for newly diagnosed localized prostate cancer. So not entirely relevant to the oncologists listening, but certainly provocative in the sense that there seemed to be a signal that this injection given does reduce the chance predominantly of intraprostatic recurrence at a 2-year time period, which is why the phase 3 was positive, and does provide an important paradigm going forward in terms of things you could do to augment the activity of external beam radiotherapy. Then there was a multimodal artificial intelligence model to identify people that will benefit from abiraterone in high-risk non-metastatic prostate cancer as per STAMPEDE. That was the Arteria AI model, which I can talk about a bit later. So that was sort of a very exciting presentation in terms of who warrants abiraterone and who doesn't. And your listeners will be aware of that Arteria AI does have indications in a couple of areas in prostate cancer already, which people are finding very useful in terms of duration of hormone therapy and the need for hormone therapy in combination with localized radiation therapy. So that's an AI-based algorithm, which is seemingly of significant clinical benefit. The other studies that came then, there was a prognostic significance of a PSA under 0.2 after 6 to 12 months of treatment for metastatic hormone-sensitive prostate cancer based on the Ironman registry. And then there are some studies leveraging off that to suggest that obviously that's a good thing. There are now at least 3, if not 4, global studies that are looking at treatment de-intensification in metastatic hormone-sensitive prostate cancer. There's a big EURTC study. There's a Janssen study with apalutamide. So that paradigm, I think, is something we'll be looking at in the next 5 to 10 years, is de-intensification. There was a presentation from Emily Grist, which was transcriptome classification of PTEN inactivation to predict survival benefit from docetaxel, the start of androgen deprivation therapy, which is also a STAMPEDE study. A little bit hard to apply in current practice because this was a transcriptome signature of PTEN inactivation, which did not correlate with IHC. So provocative, but not yet ready for real time. Alicia Morgan's presented the health-related quality of life from the ARANOTE study, which, although is somewhat controversial, at least the health-related quality of life was reassuring in that, and is now FDA approved, just post ASCO actually, in terms of darolutamide for metastatic hormone-sensitive prostate cancer. Then we moved to a 5-year follow-up of the ARCHES study, which was enzalutamide plus or minus ADT, which was a little bit disappointing that the ANZUP 8-year follow-up of Enzamet wasn't at the orals, which was almost an identical follow-up period. But both of those studies showed persisting and despite some degree of crossover benefit for enzalutamide compared to ADT alone, with an absolute numbers of at least sort of 10%. Then I'll just focus on now the AMPLITUDE study, so which was the 7th presentation, and maybe spend some time talking about that, which was niraparib and abiraterone plus prednisone for metastatic castrate-sensitive prostate cancer with patients who have alterations in HRR genes. So the bottom line is that the AMPLITUDE study met its primary endpoint of rPFS, and the reason why this is so important for patients and for your listeners is it was the first trial to show efficacy with a combination of PARP inhibitor and ARPI in metastatic castration-sensitive prostate cancer with HRR gene alterations. And obviously, the listeners will be aware that this has come on the back of a lot of work in terms of PARP inhibitors in prostate cancer, ranging from the initial monotherapy studies, which was the original TOPARP study, the phase 2 study published in New England Journal, and then moving into monotherapy studies such as PROFOUND, the PROFOUND study with olaparib, the Triton-3 with rucaparib, Galahad and niraparib, and TALAPRO-2 with talazoparib, TALAPRO-1 with talazoparib. So those studies provided the basis for the current indications for these drugs to be used as single agent. And then we heard about last year and the year before about the combination studies with PROPEL, Magnitude, and TALAPRO-2 in first-line CRPC. They still obviously have a role, but a lot of people these days, a lot of men these days, they do have these gene alterations, are not getting ADT alone. So the combination up front is useful to know that there is benefit. And this study that we're talking about now, the AMPLITUDE study, was the first where they gave the drugs up front for patients with newly diagnosed metastatic disease. And so there's a number of important points to appreciate. The first one is that patients with HR gene alterations have very poor prognosis. Some of the data presented actually in some of the posters at the meeting suggested that the hazard ratios are probably pushing 2 for patients that have HR gene alterations in metastatic castrate-sensitive disease. And so in AMPLITUDE, men were randomized 1-to-1. There were 696 men that were randomized 1-to-1 for niraparib abiraterone ADT versus placebo abiraterone and ADT. And they had to have at least one HRR gene alteration, which are the usual suspects, BRCA1, BRCA2, BRIP1, CDK12, CHEK2, FANK, PALB2, RAD51B, and RAD54L. So those were the main inclusion criteria. There was a sort of sequential design based on the primary endpoint, which was rPFS by investigator review, and then secondary endpoints, including time to symptomatic progression and overall survival, importantly, and that will become relevant as we get to the nuts and bolts. So the primary endpoint was this radiographic progression-free survival. And so in the BRCA mutant, and we know from all the literature that patients with BRCA mutations do better than patients, do better with treatment and have a greater proportional benefit than non-BRCA mutations. So it's a more profound phenotype. So the combination treatment reduced the risk of radiographic progression or death by 48% in the BRCA mutant group and 37% in the HRR population, with the medians being for the BRCA mutant not reached versus 26 months, and for the HRR mutant by intention to treat being not reached versus 29 months. So these both had very small p-values and the reduction in risk is mentioned. So that's pretty important, that giving these drugs upfront can result in a meaningful difference in the patient's radiographic progression-free survival. There was no difference by subgroup analysis, really, and the time to symptomatic progression also looked similar in terms of the hazard ratios, reducing the risk of symptomatic progression in both groups, close to 50%, slightly over. The secondary endpoints for overall survival were trending, only 50% of needed events, to show that there was a reduction in the risk of death by 25% in the BRCA mutant group and 21% in the HRR mutant group. So that's also moving in the right direction. Hazard ratio is 0.75 there, in both groups, median not reached. But again, seemingly doing the right thing. And the subgroup analyses showed probably that there was benefit, obviously, in the BRCA groups as well as in the other genes identified. I think low numbers in the PALB2 group meant that there was actually the median benefit was actually on the wrong side of the curve, but I think everyone is pretty much convinced that PALB2 functions akin to BRCA. So, and there were some small numbers, but we could be relatively assured that in those gene mutations that there is some degree of benefit in having a PARP inhibitor. There's always been some controversy about CDK12 as to how robust that is as a biomarker of DNA repair. Maybe with the passage of time over the last few years, it has become clear that it is. There was also some data about it may predict response to immunotherapy, but that may not be as helpful as we want it to be. Those tumours tend to have more lymphocyte infiltration, but whether that's meaningful in terms of a therapeutic ratio and benefit that is still being explored, but may not in fact be as hopeful as we anticipated. The other obvious thing is toxicity. As your listeners will be aware, there are concerns with PARP inhibitors in terms of side effects. They are predominantly those related to myelotoxicity. And certainly there was myelotoxicity, for example, grade 3 anemia, 29% versus 5%, neutropenia, 10% versus 2%. For example, there was also a signal with hypertension, which was 27% greater than grade. These are all greater than grade 3 that I'm talking about versus 18%. So they did not report any MDS, but obviously that's a concern, especially if the men are taking these drugs for a long time. And that certainly something that issue of MDS certainly came to the fore in another presentation that I can talk about in terms of the emergence of MDS with lutetium and with cabazitaxel, in fact. So I think that was definitely the highlight in terms of the oral session. There was this AMPLITUDE study. It's paradigm shifting. It certainly will be something that will occur to me when I have patients in front of me, predominantly at this stage more for the BRCA patients, increasingly then, and will provide the impetus to actually do the testing up front. So testing, NGS testing in Australia is becoming increasingly cheap. When I started doing this gig, you were looking at close to $5,000, I think, in 2004, 2003 for an NGS panel, and we're now sort of in some providers are now pushing a really large NGS panel down well below $2,000. So it'll certainly lead me to to be more proactive about my NGS sequencing for patients that come in. and obviously there's some reimbursement issues, but certainly for patients that do find a BRCA mutant, this data, I think, warrants a discussion with the patient as to whether that's something they potentially could embark upon or would head towards. Obviously, clinical trials would be another mechanism to get it. There have been some trials that have offered next-generation PARP inhibitors and some phase 3 studies which are accruing at the moment. We're doing, for example, the PETRANA study, which combined a variety of ARSIs with a variety with the AstraZeneca 5305, just a selective PARP1 inhibitor. That study's nearly fully accrued, and there are some now phase 3 studies with that combination accruing as well. So I think watch this space, but certainly we've got an important line in the sand, and we've got other trials to follow that will be important to validate this strategy.
Anthony, I had two. You half answered one of my questions just about when do you do the BRCA testing, because most of the time as it stands you do it in the castrate resistant space. So would if say money is not an issue, would your standard of care now be to just do BRCA on everyone that's sort of metastatic hormone sensitive who comes through your door?
That's certainly the way
there's no money issues.
Yes, that's certainly the way I'm heading for sure. Yeah. I think that we need to do that to provide the best standard of care for patients, and there'll be other biomarkers that will come in terms of P10 deletions, et cetera, that we may already know actually may affect RPFS and may in fact affect OS in the future. So those studies are underway. So I generally think that certainly if money is not an issue, understanding as much about the tumour, and you'll pick up things with such as Lynch syndrome associated tumours and other things that may give you opportunities for treatments. I've got 2 or 3 patients with prostate cancer, Lynch syndrome, that otherwise wouldn't know about. So I'm certainly heading towards that position if cost is not an issue, and even if cost is an issue, there are some mechanisms that one could avail oneself of, perhaps on the PBS or with other providers that will use that PBS rebate. MBS rebate.
And my one other question, and this is definitely not based on the AMPLITUDE, but I did want to get your take on it, is that we've got all these patients who are already on RCs or RPs who may or may not have one of these aberrant genes that we haven't tested for. If someone comes into your clinic, it's like, hey, I heard you listening on this really great podcast. It was called Oncology for the Inquisitive Mind. You're very eloquent. And they're like, hey, should I get myself tested? I'm on enzalutamide or apalutamide already. Like, would it be worthwhile me funding this? But I've been on the Enzamet trial and I'm 6 years down the pathway. And this is a terrible example because you probably wouldn't change that treatment because they're doing so well. But let's say it's within the first 12 months of them being on an RP. Would you potentially offer them to up-regulate their treatment scheduling, or would you kind of keep them on the standard pathway and then essentially move them to the castrate-resistant space at some point and then potentially give them a PARP inhibitor?
Well, first I would tell them that Oncology with the Inquisitive Mind is somewhat a dubious podcast, and we have to be very careful of the doctors that are on Oncology for the Inquisitive Mind in terms of what they say. But putting that to one side, let's assume for the time being. So I think, obviously it depends how quickly they're progressing on what's going on. So certainly if someone's on one of these drugs, enzalutamide, etc., and their PSA is slowly going up, that's a good time to get testing. Reimbursed testing in most jurisdictions globally. So if their PSA is down at 0, then maybe not. But no rush. But some patients prefer to know, and I've had conversations with patients to say, well, we don't need this information, but do you want? It may give us some prognostic information, which it will do no matter when you do the testing. So do you want that information now, or do you want it only when we need it in terms of drug treatment? And the different patients have different perspectives about how much they want to know. And so we usually discuss it in that context.
Anthony, you've given a lot to chew on, a whirlwind tour of ASCO GU in the prostate space for people who weren't there. But I did want to draw further special attention to, because it's often not, doesn't reached the bulletin board. But was there anything in sort of the smaller, earlier phase realm that you thought might represent an exciting new direction, or filling a hole, not ready for prime time, obviously, but anything that might change things, how we look at prostate cancer in the future? You mentioned the P10 expression, and obviously a lot of this stuff will be biomarker, but was there anything in that space that jumped out at you during ASCO?
Yes, so there was a study actually in the prostate rapid orals, which was lutetium and oligometastatic hormone-sensitive prostate cancer. So in this study called the Bullseye study, they gave lutetium. There were 58 patients, only 1-to-1 randomization of lutetium versus observation. So 29 in each arm, and they basically had patients who were high risk, so PSA doubling time less than 6 months, PSA above 1, SUV greater than 15, less than 5 lesions. So very adventurous in terms of the PSA doubling time and the ability just not to treat them. And they showed that there was an enormous sort of progression-free survival and time to PSA progression benefit with hazard ratios of 0.07 and 0.09 respectively. They allowed patients to crossover, and actually the men that crossed over actually did well in terms of, there was no difference in terms of survival. They had PSA response rates in the treatment and in the crossover arms in the treatment arm. It must have been a sort of 70-something%. I'm just trying to recall the number. And 25% had complete biochemical responses, which persisted in 16% of patients. So giving lutetium without hormone therapy is one of those, again, very provocative ideas that certainly men in my clinic would appreciate, and I get asked that question not infrequently. And the correlative of this is that, again, something your listeners should be aware of is that PSMA addition, which was a study that was completed, was reported during ASCO by press release, which was ADT plus ARPI plus 6 doses of lutetium versus placebo, was reported as positive. So a lot of people have concerns that that study would be negative because after probably 2 doses of lutetium 12 weeks and an ARPI, all your target is gone. So all you're doing is putting lutetium in and getting it peed out. So there was a lot of concern this would be, this study would not be positive, but in fact it is. So we're yet to see that data. That may come at ESMO. I think ESMO is shaping up to be a great meeting for prostate and bladder. If you or your colleagues are thinking about traveling later in the year, although I don't know that PSMA addition is going to be presented at ESMO. So there's certainly some very exciting stuff in this early phase space, and this Bullseye study is again very provocative in terms of what can be done with a non-hormonal active agent in prostate cancer. It does link into the concern about clonal hematopoiesis, however, which was brought to bear by a presentation by a PhD candidate actually at the Vancouver Prostate Cancer, Asli Munzoor, on behalf of both Vancouver Group and ANZUP, where they looked at clonal hematopoiesis in men receiving PSMA 617 or cabazitaxel on the therapies study. And so that was, I guess, concerning to the extent that there was progression of clonal hematopoiesis to a greater extent with lutetium than cabazitaxel, in particular with PPM1D mutations, which is a sort of high risk. So that was during the course of treatment on therapy study, the emergence of clonal hematopoiesis in 62% versus 40%, and with this PPM1D, 34% versus 8%. So So that's of concern when you're giving more doses than you need to, and in men who are going to live longer in terms of the emergence of MDS or AML, et cetera. So and not to mention the potential effect on the kidneys. So certainly something we have to be very cognizant of. I don't know how and when PSMA addition may be submitted to FDA in terms of approval and what further data they would need. Probably going to need more overall survival data, and certainly some data about the emergence of secondary malignancies and kidney damage, given that information. So this adaptive dosing in terms of giving just 2 doses of lutetium and then waiting may be where the field moves, which would be sort of PSA-directed treatment. And that is also the subject of ongoing clinical trials, but not in this PSMA addition study, which has just been, by press release, declared to be positive.
And obviously the current crop of ASRIs, RPs, there's so many names these days, but they're really impressive drugs, and you hinted at it. The men who get these medications, really regardless of which agent it is, are going to live much, much longer. How do you see a way with all of this emerging data in PSMA, lutetium being shoved more to the castration sensitive or the earlier phase of treatment? Do you see a way that it can sort of get a place for itself, given some of those concerns about toxicity that you mentioned? If it is better, is there still going to be, in terms of PFS and OS, is there still going to be some concern about toxicity from your practice?
Oh, and to some extent, it's obviously generally very well tolerated, so that's the upside. We're certainly moving, I think, towards combination therapies based on studies such as the ENZA-P study, which showed there was a benefit to taking enzalutamide plus lutetium versus just enzalutamide that came out of ANZUP as well. So I think we're definitely moving to combination therapies, but I think we're going to have to take each man as an individual and see the extent of disease, the prognosis of disease, whether we need to hit them hard, or we can do something like give them non-castrating lutetium treatment one day without any ADT. So all those things we'll bear in mind. There is a study called PSMA DC, which is a study with men of oligometastatic disease, which is SBRT versus SBRT plus lutetium. That study has a conventional imaging endpoint, is accruing, as to my understanding, also as well, to explore that paradigm of keeping men off hormone therapy, which is, I think, ideally where the field will end up. But there's some very exciting agents that are in the pipeline for prostate cancer, which in the more advanced setting, which will certainly move their way back into the up the disease stream. One such agent that was mentioned at the meeting was the Johnson & Johnson KLK2 CD3 drug, which is called pasritamig. So this drug binds the thing called KLK2, which is like of the same family as PSA. It's very restricted to the prostate gland itself. It didn't have much in terms of CRS, and there was a 42% rate of PSA 50 response, and a median duration of response of close to 9 months. So that was one of the many exciting agents I think will come up the pipeline. The other one that was presented also by Dr. Parsonson at ASCO was the BNT324 or DB1311, which was a B7H3 ADC. So this study, this ADC is also very promising. They didn't actually report out PSA response rates. They reported out overall response rate in terms of RECIST, which was about 40-something%. So you could probably extrapolate the PSA response rate was very high, and the radiographic PFS was actually not reached, but at, for example, overall was sort of 58% at 9 months. So that's also another exciting agent. So I'm very excited about what ASCO 2030 2030 is going to look like with all these new agents coming down the pipeline, because there are a lot of them that will be very exciting. And I was also brought to my attention is a company called Vir Therapeutics, Vir Biotechnology, that have got a masked PSMA CD3, which also shows that with that drug, they had a PSA 50 response of 58% on their website. So look, very exciting in terms of what the future holds in terms of prostate cancer with drugs with novel mechanisms of action, not chemotherapeutics, and lower toxicity than what we've been used to.
Yeah, very, very interesting. And I think the prostate world gets more and more complicated as the days progress, which is going to be the joys of not knowing which drug to choose. Anthony, we could always chat for hours. / you could always beat me in a race. But what I wanted to know just before we sort of wrap up today, was there anything else that sparked your intellectual interest? Any final sort of like, oh, that could be cool, or that might be interesting. I'd love to bring that trial to the Kinghorn and pioneer something here. Was there just one final study of what you saw that you think your listeners or your fans might want to read about?
That's a good question. So many to choose from.
It's a bit like Taylor Swift. Is Anthony our Taylor Swift?
I don't know how prostate cancer is like Taylor Swift. Though actually last year's ASCO, Taylor Swift was performing at the field as the meeting was going on, or at least as it finished a couple of the evenings. So I could hear Taylor Swift from my hotel room.
Oh, brilliant!
At last year's ASCO, not this year's ASCO. Any other little tidbit? I think the drug development space is fascinating. I think those last 3 new agents I mentioned were certainly very exciting. So they're probably the things that I'm always excited about, the new drugs coming down the pipeline in terms of what we can learn in terms of ways to attack prostate cancer. Ultimately, one day the dream would be not to give men ADT at all and to treat them without ADT. We'll end up one day like our breast cancer colleagues who've got at every decision point 3 or 4 different options to choose from. So we're getting there, and I think it's exciting times ahead.
Exciting times indeed. Anthony, thank you so much for coming on. It is always great to hear your fountains of wisdom and great to get your interpretation of ASCO rather than just what Josh and I do, which is just reading numbers off a sheet. But it's great to hear from one of the great minds in this great country of ours.
The court jester, as we displayed.
Court jester with hidden influence over the monarchy. But
okay.
Thank you so much for coming on. Join us next time as we continue our sojourn, as Josh called it, through ASCO. Who will it be? Well, you'll have to listen to find out. We'll see you next time.
See ya. Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you like this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.